right, we are wrapping up with anatomy of selected synovial joints. So we're going to look at exactly which bones articulate together to form these synovial joints, what movements are going to happen at each of these joints, and then some of the structures that are going to support the joints and prevent excess movements. And those excess movements are what would cause injury if they do happen. All right. So first up is the joint here at C1, C2, so between the atlas and axis vertebrae. All right, so again, this is going to have some discs, so it's going to have that intervertebral disc in between this kind of upper portion. It's not going to be very large, but it's going to be located up here for a little bit of cushioning. But this joint, because these are such unique vertebrae, and again, these don't really have that body that the other vertebrae in the column have, so we don't have a very large disc there. So these are held together mostly with some ligaments and other connective tissue. And so you can see right here we have something called the transverse ligament that is anchored on that C1 vertebrae, so the atlas, and it's kind of surrounding the dens of the axis vertebrae, allowing those vertebrae to actually stay together and providing that movement, that rotational movement that lets us turn our head side to side. All right, and so this is one of our top joints, sometimes called the atlantoaxial joint. And then you can see here on the atlas, we've got some articular cartilage here on this facet, and that's what the skull is going to rest on. So we have that cartilage cushioning there, but we are focused mostly on this area right here of that joint formed around the dens of that axis bone. All right, so two bones involved here, some ligaments, especially this transverse ligament, really, really important, but allowing that side-to-side rotation and a little bit of flexion and extension here at this joint as well. So this isn't the main joint that's allowing for that flexion and extension of the head, so if you kind of flex and extend your head yourself, you'll notice that that movement is occurring all along the neck, and so it's not just isolated up here to the atlas and axis bones. All right, and so that's our first of the synovial joints that we're looking at specifically here. And then our next one is the temporomandibular joint. So if you've ever heard of something called TMJ, that is inflammation of this specific joint. We'll learn more about these different components when we cover the skull and lab next week, but this is an articulation between the temporal bone of the skull right here, the mandible, which is the lower jaw, and how those kind of fuse together there. All right, so this is going to allow for us to open and close our mouth, so that's depression and elevation of the mandible, which is again the lower jaw, so that's the only part of your mouth that actually like moves when you're opening and closing your mouth is the mandible. There can be a little bit of protraction and retraction motions, but looking at this joint, you can see there's not going to be a whole lot of movement kind of forward and backward, that protraction and retraction, because there's just not a lot of space here, and it's a pretty small joint that's set in pretty well, and it's pretty stable, which is important. We don't want our lower jaw moving around too much, because that would be bad. All right, and so you can see we've got the mandible down here. Here's our mandibular condyle. We'll revisit that in lab. It's covered by that articular cartilage right there. And then we've got some articular cartilage on the what's called the mandibular fossa of the temporal bone up here. So there's our cartilage there. And then we have this extra disc of cartilage in between in that joint cavity called the articular disc. So this is just some more cartilage in here to help provide a little extra cushioning and stability. All right. But otherwise, we still have the other features of synovial joints. So we've got that joint cavity filled with synovial fluid. We have that synovial membrane out here, and then our articular capsule kind of helping to really adhere both of these bones together, that fibrous connective tissue to really anchor those bones together. And so that flexible articular disc is just going to help fill that gap and to help kind of smooth out the movements here, to make this a little bit more of a smooth process and keep these two ends from rubbing on each other too much. All right, so again, opening and closing the mouth, slight gliding motion, so protraction and retraction here, but not a ton of those. It's mostly going to be that elevation and depression of the mandible. This can get dislocated when people open their mouth too wide. That's not super common to dislocate this. It's a relatively stable joint, but it is possible to dislocate it. The other time that can be dislocated, other than opening the mouth too wide from trying to take like a really big bite, that could happen from like trying to have a jawbreaker or something. But also blows to the jaw, so getting punched in the face or getting your face slammed up against something can also cause a dislocation of this joint. So that mandibular condyle right here would move basically forward a little bit because there's not a lot of space for it to go back. There's some other bony structures here in the way, so it's going to go forward more than it's going to go back. And there's not a lot of space for it to kind of move laterally or medially either, which is why we're mostly just going to get that anterior movement forward. And so if that gets dislocated, you're not going to be able to close your mouth at all because this joint is not seated correctly. And then, like I mentioned earlier, TMJ, the temporomandibular joint disorder, this is a really painful condition that can be caused by arthritis and some muscle fatigue. So this articular cartilage in here can start breaking down, causing that arthritis, starting to cause these bones to actually rub more directly on each other and not have that extra cushioning from that cartilage. So that's very, very painful. There can be a lot of muscle fatigue because people grind their teeth, further damaging all of that cartilage, and then jaw injuries can also contribute to that disorder. So TMJ disorder is pretty serious and affects people's lives pretty dramatically because this is such an important joint. If you've got a lot of pain there, then it's going to be harder to eat and stuff like that, which is going to affect quality of life. And these can also cause headaches, and sometimes people lose their ability to move their jaw at all because it's just so painful and all of this tissue in here is so inflamed and stuck together that there's not a lot of movement there. So there are some helpful therapies like bite guards and stuff, but it's a pretty serious condition. Next up is our shoulder joint. So this is going to be formed by the humerus, scapula, and clavicle. So they are all playing a role here in that shoulder joint. This is also sometimes called the glenohumeral joint for that glenoid fossa or glenoid cavity, and then the humerus. So glenohumeral joint. Again, this is another ball and socket joint. This has the largest range of motion out of any of the joints in our body. This is the only one that we can move as freely as we actually do. But like I mentioned in a previous video, freedom of movement means a lot more instability. So this is a very weak joint compared to a lot of the other joints that we have in our body that don't have as much movement allowed in them. So this is why shoulder injuries can be pretty common. It's really pretty easy to get rotator cuff injuries and stuff like that. So this is a pretty weak joint. All right. So we've got this articulation up here. So we've got our articular cartilage on the surface of our different bones there, providing a little bit more of a smooth movement. We've still got that synovial capsule in here with the membrane and everything, synovial fluid in there. In this case, it's also called the glenoid cavity, the space in between the bones. All right. Then we've got that capsule made out of the two membranes, some of that connective tissue holding some of these bones together, really anchoring them together. We do have some bursa here, so we have the subacromial bursa sitting under the acromion end of the scapula. So that acromion process of the scapula up there. And then here's where that clavicle comes in. So that bursa is just going to provide a little extra padding there in between the acromion process and the top of the humerus. So we've got that little extra cushioning when we raise our arm up and stuff like that and move it around. So lots going on here, as you can see, lots of different cartilage and ligaments and everything. We've got tendons in here, so tendons connect muscle into bones. So we've got the tendon of the biceps right here that's going to anchor into this articular capsule through that tendon sheath. That's going to be further anchored back towards that scapula there. And so we've got a little bit of fibrocartilage in there as well, kind of over here, offering a little bit extra cushioning and a smoother surface for movement. All right. And then we've got a bunch of ligaments. So I'm not going to go into a lot of detail about all of these ligaments, but we have a lot of ligaments holding the shoulder joint together, which is part of the reason why it's easy to injure your shoulder and have those rotator cuff injuries. All right. So most of the support for the shoulder joint is from the muscles that cross this joint rather than the cartilage and tendons and ligaments and stuff. It's a lot of support from the muscles. And there are 4 muscles that make up the rotator cuff. We'll cover them in our muscles unit, but they are the supraspinatus, infraspinatus, teres minor, and subscapularis. So a lot of these are anchored onto the scapula initially, and then to connect out here via tendons onto the humerus and stuff like that. The teres minor is going to be down kind of here in the armpit area towards the posterior side of the body. And so as these muscles kind of come across that shoulder joint, the tendons are going to wrap around the head of the humerus here, offering a little bit more stability, and they're going to anchor into that articular capsule out here that we see circling this joint. So that's where a lot of the support here is coming from, rather than just bones being really close together. All right. Further muscles like the deltoid and stuff that's going to wrap over the shoulder is also going to help lend some support, but those rotator cuff muscles are the main ones supporting this particular joint. So really common to have injuries both from repetitive use, so throwing motions, swimming, stuff like that. Any racket sports like tennis can cause a lot of issues with this particular joint. Those can all lead to inflammation of the bursa or the tendons, and that can be chronic or acute inflammation, so long-term or short-term. And then that's going to be really painful. It's going to take some time and rest to let that inflammation go down. A lot of those repetitive motions can also degenerate the muscles making up the rotator cuff, so it can start breaking down those muscles because they're doing so much work. All right. And this is also a really easy joint to dislocate because muscles are strong, but they're not as strong as bone is. And so if there's a big enough force, then they are not going to be able to hold the head of the humerus in place in that glenoid cavity, keeping it close to that scapula. So very, very high risk for injury here in the shoulder joint. Next up is the elbow joint. Again, this is a uniaxial hinge, so we can do just a couple movements here. And so this is the joint formed between the humerus, radius, and ulna. And so This is also going to be a synovial joint, but as you can see, there's a lot more ligaments and stuff involved here than what we saw in the shoulder. So up here in this panel, the humerus is going to be up here, and then we can see our ulna right there. So we can see the olecranon process, the trochlear notch right here and stuff like that. Coronoid process over here, coming around the trochlea on the humerus. We've got some bursa sacs in here underneath those tendons, offering a little bit more cushioning. All right, so anywhere you have bursa, you can get something called bursitis, which is inflammation of these bursa sacs. It can be very, very painful, just like tendonitis, which is inflammation of these tendon sheaths that are encapsulating these tendons right here, connecting muscles to bone. So there can be a lot that goes wrong with the elbow also. So you may have heard of something called tennis elbow. That comes from, again, repetitive motions of things like playing tennis. So a lot of that repetitive flexion and extension at the elbow joint can cause that tendonitis and bursitis. So we have a lot of those bursa in here. So we've got the olecranon bursa back here at the posterior side of the elbow, sorry. So that can get really, really inflamed. There is a nerve that's going to run through here, and that's the quote-unquote funny bone. It's not actually the bone, it's you hitting the nerve and that getting compressed up against the ulna. That's very, very painful, as I'm sure we've all experienced at some point in our life. And then we've got a single articular capsule all the way around all of this, made up of that fibrous connective tissue and the synovial membrane, with that synovial cavity and fluid in between the trochlea and the ulna. All right, and then we've still got that articular cartilage to help make this a smooth gliding motion and provide that extra cushioning. And then we also have some fat pads in here. Those are also going to help with a lot of cushioning for those tendons and keeping those from rubbing directly on bone or these other connective tissues. All right, so not as much movement here, so we're not as at high risk of injury at the elbow joint, but like I said, we can still get a lot of inflammation of the bursa and the tendons, causing some pain and a little bit of weakness sometimes, depending on how severe it is, but it's much less likely to dislocate this joint. Not impossible, but less likely. As you can see here in these medial and lateral views, we have a lot of little ligaments holding all of these bones together near each other, so that's going to help offer a lot of support instead of the muscles that we saw holding that shoulder joint together. All right, so lots and lots of ligaments. Ligaments are really strong. They are connecting bone to bone. That is their job, is to hold bones together. And then we've got our hip joint. So the hip joint is pretty movable, not quite as big of a range of motion as the shoulder, but similar, just not quite as much, because we can't quite get that femur up all the way out here because of all those bony projections in the way and stuff like that. So this is another ball and socket joint though, with the head of the femur and that acetabulum. So just like our other synovial joints, we've got that cartilage, we've got our synovial capsule in here with that cushioning fluid. We've got some ligaments in here also. There are tons of ligaments helping to hold these together. Lots and lots of ligaments, offering a bit more stability, which is really important for the hip joint because we do not want those joints to dislocate. Shoulder joint dislocating is bad enough, but it's definitely not the end of the world. A hip joint dislocating can be very incapacitating. All right, so that's going to be incredibly painful. It's very hard to get a dislocated hip back in place because that acetabulum is so deep and these ligaments are so strong. It takes a lot of effort to get this rearticulated correctly in the case that it does dislocate. But we need that stability because this is how we are able to do a lot of our movement. This allows us to stand and walk and stuff like that. So limiting that range of motion a little bit and having more of these ligaments is going to support the hip joint a bit more, give it a little bit more stability than what we see in the shoulder, because that shoulder joint, it's not supporting a lot of our weight most of the time, unless we're doing certain types of workouts and stuff like that. So it doesn't need as much stability as that hip joint does. All right. And then the knee joint, we've already talked about this a little bit. We've covered all of those different bursa, so we could get bursitis and tendonitis down here too. Just like any other joint, if there's a tendon or a bursa, you can get inflammation of those particular structures. They're going to be a little bit painful, but they're usually going to clear up with a little bit of rest and care. And then again, we've got those menisci, the medial and lateral meniscus inside, cushioning in between the femur and tibia bone, and then a lot of ligaments inside, kind of passing through the middle part of that knee, as well as more ligaments on the outside. So we've got those collateral ligaments on the side. We've also got these patellar retinaculums, kind of on either side of the patella. We've got the quadriceps tendon, the patellar ligament. Lots and lots of connective tissue here to help hold this knee joint in place. So this is another pretty stable, strong joint. Again, this is supporting a lot of weight. We need to have our knees functioning properly to be able to stand and walk pretty well. So lots of stability here. We're not relying exclusively on those muscles to help hold this joint together. We're relying on that connective tissue. All right. So a lot of these ligaments can also come from higher up in the leg a little bit, interestingly. So that's partially this quadriceps tendon. So we've got those quad muscles and then that tendon. But this is all anchored higher up in the hip as well, offering a lot of stability to that joint. And so we really need our knees to be in good shape, obviously. Not a huge range of motion. Again, we're mostly looking at flexion and extension at the knee, which is further supporting that stability aspect of the knee joint. So lots of cushioning because we're putting lots of pressure on here. That's why we have that extra cartilage in here. And then really keeping those two bones close together for that stability and support is super, super, super important. All right. So everybody's probably heard of ACL tears before, so that's that anterior cruciate ligament there, and that is a pretty easy one to tear, unfortunately, depending on how pressure gets applied to the knee. You can also damage like the collateral ligaments. I've injured my lateral collateral ligament before because I actually had a couple dogs that were playing that just slammed into my knees. Not their fault. It was an accident, but it was really painful, and it was a pretty quick injury, and there wasn't even that much force that actually got put on that particular ligament on my knee, but I got to walk around with an immobilization brace for a couple of weeks, so I got to walk like a penguin, which was not fun, because I was still a student at the time. All right, but that ACL, that anterior cruciate ligament, so depending on how the knee is hit can determine what is most likely to tear. And so if you get hit at the lateral side of the knee, so over here near the fibula, that can cause kind of a sequence of 3 injuries. First, tearing the tibial or medial collateral ligament in here, because if you're putting pressure this direction, then that's going to put a lot of force on that ligament, so it can tear that particular collateral ligament. It's also going to damage that medial meniscus that's over here, so this one right there in between the tibia and femur. And then that's also going to lead to the anterior cruciate ligament rupturing due to that. The posterior cruciate ligament can sometimes rupture in an injury like that, but it's less likely. Sorry, I went too far. But because that posterior cruciate ligament isn't going quite as much in between the bones, it needs a bit more force frequently in order for any injuries to happen to that, whereas that anterior cruciate ligament happening at a diagonal is much more likely to tear. So that's why you hear of ACL tears more commonly than like the posterior cruciate ligament. All right, let's talk about our ankle and foot joints now briefly. So our ankle joints are formed by the tibia and fibula meeting some of those tarsal bones, especially that talus bone. That's what the tibia is going to be sitting on top of. This is a pretty stable joint. As you can see, we have a lot of ligaments in here. There is going to be that cartilage in between the bones to offer some support and cushioning and stuff like that. But lots and lots and lots of ligaments helping to hold all of these bones together. So this is a pretty stable joint. Again, it's our lower limb. Without stable lower limb joints, we can't stand and walk as well, if at all, depending on the severity of the injury. So we want that extra stability. We don't need as much movement and a big range of motion like we do in our upper body. And that's just based on human evolution and the fact that we are now bipedal organisms and walk on our two hind legs instead of on four legs. All right, so really nice stable joint here at the ankle, but obviously too much force can cause some injuries. I'm sure most of you, if not all of you, have sprained your ankles before, at least once, hopefully only once. I've lost track of the number of times I've sprained my ankles. There was a year, I think, I re-sprained my ankle every single month. It was awful. We can never figure out why, though, but any sort of kind of too much rotation, inversion or eversion of that foot can put a lot of pressure on the ligaments on one side of the ankle or foot or the other. Being stepped on can cause a lot of issues there. It can fracture bones as well as tear a lot of these smaller ligaments and stuff like that. So there's always a risk of injury, but the more ligaments we have helping to support that, the more stable that joint's going to be. And then ligaments don't heal themselves very well, which is why sprained ankles can sometimes take a really, really long time to actually fully heal up and start feeling better. And that wraps up week 4.